very risky because the vessel is almost closed. The flow is slow. So it is better to go for percutaneous intervention. But percutaneous intervention, you should do image guided. You should look at the OCT, and also you should also try and do some thrombus reducing techniques. So one of the most important thrombus reducing technique is laser angioplasty. Laser may help in reducing the thrombus load, and then direct stenting without much balloon dilatation, if it is possible after laser, that may help in doing the job. I hand over this mic to.
You have shown 4 points. Now we'll discuss one by one. Next, imaging. What kind of imaging you want to do? Regarding plaque modification, you can throw a light. Partha, you can discuss.
So, by my imaging choice of modality is OCT, because OCT is a high definition imaging technique, and where we can see whether it is a white thrombus or red thrombus, we can clearly delineate. And IVUS also we can do here, but however OCT clearly shows more resolution, and also we can assess the thrombus whether it is a white or red thrombus, and also we can see the stent expansion, everything. So my choice is OCT.
Anybody else want? Yeah.
Yeah, just to brush up, we all know the angiographic classification of a thrombus. So it is quite evident that this thrombus is a grade 4 thrombus, where the length of the thrombus is more than twice the reference vessel diameter. So by angiography, of course, it is quite a significant thrombus burden. And as mentioned, OCT is a very good option to differentiate a red and a white thrombus. And the discussion of deferring stenting, it comes up quite often during our primary PTCS. So if there is a TIMI 3 flow, we could have definitely considered deferring the stenting and giving maybe some intracoronary GP2B3 inhibitors and an infusion or with heparin. That discussion will come subsequently. But here the flow was around TIMI 2 flow. So we had that dilemma of whether or not to go ahead with direct stenting or deferring the stenting, which we will discuss.
So if you see there is a large thrombus very next to LAD diagonal bifurcation. The diagonal also tightly stenosis, and the flow is sluggish. Distally, there is a diminished flow. So any balloon dilatation, sometimes what happens, distal embolization that lead to sudden closure and further, and never implant the stent in such diminished flow with a large thrombus burden. So initially thrombus either go with mechanical thrombectomy. Those studies have shown, even guidelines, now it's a class 3. So thrombus aspiration is a class 3. But the only thing is mechanical aspiration using the now Inari catheter, a cheetah study that showed CAT-X, that showed superior results. But only thing is, this is relatively organized thrombus. So acute going, acute onset, ST elevations, ongoing pain, that time you can give even intracoronary thrombolytic, wait and see. But we have a wonderful device, that is laser. Laser, as Dr. Shailendra Singh pointed out, there are 3 mechanisms. Any one of you discuss the mechanisms, Rajaram?
Yeah. So ELCA basically it acts in a 3 ways, sir. It is mechanical as well as chemical disruptions of the bonds with the fibrotic bonds, and all those things will be broken away. And then mechanically it creates some micro bubbles, which again helps in dissolution of the thrombus. So ELCA is an ideal choice, particularly in the large thrombuses, where it can modify the character of the thrombus. Sometimes it may reduce the significant portions of the bonds which are involved in the relatively organized thrombus, and then it helps in the recanalization and free flow of the blood.
So as he highlighted, three major aspects of the ELCA. One is it cleaves the molecular bonds. It separates. It indirectly cleaves the bonds so that it becomes a small, it disintegrates. And then because the thermal, it coagulates. Underlying that, the cells become necrose, thermocoagulation. And during the process, it also generates a microbubbles. So microbubbles also almost generate 40, 50 atmospheres. So combined effects, it can cause the plaque burden will be less, thrombus get disintegrated. That is the mechanism. So when thrombus burden is less, the slow flow, no flow is less likely. Even it also acts on the fibrocalcific lesions. If thick fibrous lesion is there, it can ablate the proximal lesion also. Simultaneously, diagonal also, if you do it, if fibrotic lesion is, you can do the plaque modification. And if then that time already he has mentioned two options, whether to go with provisional or R2 stent technique. If L6 is modified well with a laser and cutting balloon, with a simple balloons, then you can go with provisional. You can go with DCB into the diagonal and LED into the stent. Two stents because the MACE rate is going to be very high, two stents. So provisional stent is less. Here, like a hybrid strategy also we can think. Or we can go with a simple DK crush. But the lesion in the diagonal is very, though it's very big vessel, but the lesion is very short, less than 5 mm. I think provisional stenting would be a great opportunity in this case.
So here we are with the opinion that we go with provisional stenting. So one more comment about the LAD. Anything obvious noted in the LAD apart from the thrombus? Yeah. So there is a significant myocardial bridge which is noted, because I'm telling this because when we proceed ahead, we might think that something new has occurred here. So we've spoken about ELCA as a modification for this thrombotic burden, but ELCA being not available at major centers. But if we talk about other modalities for modifying this therapy, so what are the other modification things which can be thought of, or who is of the opinion that we should go and stent directly and plaster the thrombus, or we give intracoronary thrombolytic, bring the patient back after 2 days and do a stage thing, or we do a thrombosuction here and go ahead with the procedure.
Bhatia, do you want?
So the common approaches with regard to high thrombus, basically the ideal approach will be to look for the symptoms and ongoing ischemia. That will guide our approach, because we know that, as madam has rightly pointed out, it is a high thrombus lesion. So in centers where we are not equipped with the thrombectomy or plaque modification device, if the patient is not having ongoing ischemia or is hemodynamically stable, then the approach with the intracoronary thrombolysis is a wise approach. We can basically go ahead with that and then defer, and then we can go for a check angio after 48 hours. However, if the patient is hemodynamically unstable, if there is ongoing ischemia on table, then definitely going ahead with the mechanical thrombectomy is one of the approach. Another approach which has also been talked about is a use of a guide liner for an aspiration instead of the, when mechanical thrombectomy catheter is not available. So we can go for a 1:1 guide liner and we can try and aspirate it rather than going for a if mechanical thrombectomy catheter is not available. But symptoms and hemodynamics will be the one which should guide our approach rather than going for one way or this way. That's what my opinion is.
Regarding antiplatelet therapy, Surinder, do you want to add anything? Because high thrombotic burden, what kind of antiplatelet therapy you want to give? Any priming, like loaded with DAPT? If there is no loading of the DAPT, how do you decide?
Actually, this case presented as a ACS NSTEMI with grade 4 thrombus. And for this patient, we decided to go for deferred strategy, as there was a TME2 flow. There was no zero flow. There was a TME2 flow. So we decided to adequately give antiplatelets and anticoagulation for this patient before going for angioplasty, because we were expecting slow flow if we go for direct stenting or only balloon angioplasty. So we loaded patient with adequate antiplatelets. We have given ecosprin 300 and ticagrelor 180 milligram, and statin as usual, atorvastatin 80 milligram. And also we have given glycoprotein 2B3 inhibitors, iptifibatide, and we waited for a 1 day. And next day we did angiogram, but there was a not much regression of the thrombus. And then we
So
decided to go for HELCA.
the question here was to consider IV cangrelor in this kind of patients or not.
Yeah, this patient definitely requires IV cangrelor. The now class 2A, now indication cangrelor, because we need a very good effective antiplatelet agents. Ideally, even if suppose not loaded with a ticagrelor plus aspirin combination or prasugrel combination, if not preloaded, definitely cangrelor is the first antiplatelet of choice, because during first 2 hours, it produces the antiplatelet effect in 95% of the patients, whereas the DAPT only produces 50% antiplatelet activity in the first 2 hours. So this is high thrombotic burden. The chance of stent thrombus is very, very high. So that's the reason. But though the glycoprotein 2B3A blockers are class 3 in the recent ACC classification, but they also indicated in a large thrombus burden patient. This is a subset where very large thrombotic burden, it's worth trying. Even in the cath lab, intracoronary you can give, and you can continue the post procedure also. But a cangular with thrombectomy or intracoronary glycoprotein and 2B3A or in limited centers where the laser is not there, you can go with intracoronary thrombolytic therapy. 10 milligrams tenecteplase is also worth treating such type of patient with IV tenecteplase at 10 milligrams.
So after having opinions of every one of us that what should be the thing to be done, so let's see what does literature tells us. And so Dr. Partha will guide us through management of intracoronary thrombus in patients with myocardial infarctions.
So before going to the case per se, so we will just discuss regarding the management of intracoronary thrombus and what are the predictors of mortality in this subset of patients. So thrombus burden dictates the outcome, because when there is a large thrombus burden, there will be chances of distal embolization and stent thrombosis, and that can lead to no reflow or slow flow phenomenon. Whenever when a patient is having refractory slow flow or no flow during the procedure, there will be increase in mortality and MACE events over a period of time at the end of 1 year or 2 years also. And whether it is a platelet rich or erythrocyte rich thrombus, that is red thrombus and white thrombus, the red thrombus is refractory because it has got high fibrin content, whereas a white thrombus that is predominantly platelet rich, it is more responsive to lytics. So the thick fibrin is easy to treat compared to the thin and dense fibrin, which is resistant to lytic agents. So already discussed, this is a grading of the thrombus. So in this patient, we are having grade 4 thrombus. That is, the thrombus is having a diameter of more than 2 vessel diameters, whereas a grade 5 is total occlusion. If the patient is having grade 5 total occlusion, we have to open with a balloon. After that, we have to reassess the grading of the thrombus. So the increasing in the grading severity, there will be more chances of slow flow and no flow. So these are the morphological predictors of no reflow. One is the total cutoff pattern, and also the accumulated thrombus is more than 5 mm, floating thrombus, persistent diastasis, and also reference lumen diameter is more than 4 mm, that is ectasia. And also there is incomplete obstruction with the diameter of more than 3 times the lumen size. So these are the independently predicts the slow flow or no reflow, and also you have to be ready when you see this type of morphological predictors of slow flow. So there will be more increased chance of no reflow, and also once if you don't do anything, there will be chances of stent thrombosis also, because you can't establish the distal flow to the TIMI grade 3 flow. So what is the role of manual aspiration thrombectomy nowadays? Previously, the positive trial that suggested the routine use of mechanical manual aspiration is the TAPAS trial. Here the number is only 1000 number, and also it showed a positive outcomes and also reduced 1 year mortality. But however, in 2013, there is a test trial with the increased sample size. However, it showed no mortality benefit. And in total trial also, they showed a no CV death benefit. And also there is increased risk of a stroke because it is because of the incomplete there is more chances of stroke risk while disengaging the guide. This thrombus can have been embolized to the brain and it led to the strokes, and it's because of the improper technique. And here you can see while doing the manual aspiration, you should be preventing the deep sitting of the guide so that at the end of the tip of the guide, the thrombus can be dislodged, stuck. And while removing the gear, sometimes it can be embolized into the aorta. From there, it can go into the cerebrovascular circulation. And also while removing the aspiration also, you should maintain a negative pressure so that there won't be any dislodgement of the thrombus. And usually this stroke usually occurred within the 48 hours of the procedure. And in high volume and also highly equipped centers, the chances of stroke has been less compared to the centers where it is infrequently done. So this suggests that there is some role of the technique when you are doing the manual aspiration also. So previously, angiojet is also used in the management of the uh, thrombus burden. But however, it is not used routinely nowadays in coronaries. But however, there is some role in the peripheral thrombus interventions. And now the picking up system is the Penumbra or the Indigo. It is a continuous pump-driven vacuum. And the positive evidence for this intervention is the Cheetah study that showed that there is a decrease in the morbidity and also mortality. And one more thing is the stent retrievers, that is solitaire invest. It is nothing but a digital mesh trapping thrombus. It will just like a McGuard system previously. It has got excellent safety profile, and also there won't be any no dissection and also perforation over a period of time. But however, it has got more chances of late malposition because the thrombus will be dissolved over a period of time, leading to late malposition. What is the role of glycoprotein 3B to B3 inhibitors? So this is the commonly used drug we use in every cath lab. So whether we do have to go with the intravenous or intracoronary. So, but current standing is that it is used only as a payload strategy for massive thrombus or a large residual burden after mechanical failure. So routine use is not recommended. What we see in the peripheries is whenever the patient presents with MI, usually they will use for the glycoprotein 3B inhibitors directly without going for the angio. But however, it is not recommended. If the patient is having high thrombus burden and you have tried all the mechanical interventions, then usually it is a add-on therapy, and also it has got some benefit in patients with slow flow, no flow. So intracoronary thrombolysis is a excellent intervention. So in patients with a high thrombus burden, what we do is we have to give at least 10 to 20% of the systemic doses of the fibrinolytic. The agents commonly we use the tenecteplase in our center. We can use altiplase and streptokinase also. Altiplase in the dose of 10 to 20 mg and streptokinase in the dose of 250 international units. So it has improved ST segment resolution and also reduced the in-hospital MACE. And also there is no significant increase in the major bleeding. So we can use it safely in patients with high thrombus burden. So what is the role of direct stenting in patients with high thrombus burden? So when there is a high thrombus burden, you don't know the underlying lesion, whether it is a fibrotic lesion or the calcified lesion. So if you go for the direct, there can be chance expansion. At that time, you have to go for more aggressive balloon dilatation that can lead to persistent slow flow and no flow. So the moment you with should be taken up in selected patients where know the lesion morphology with imaging. If there is any ambiguity regarding the direct stent, however, it will lead late malposition because when the thrombus is tagged behind this vessel wall and the stent, there can when there is resolution of the thrombus malposition that can lead to adverse MACE. So the patient a TIMI3 flow established on the day of angio. So you can leave the patient with a high thrombus burden for intravenous GP2B3 inhibitors. So after that few days, you can do a check angio. If there is thrombus dissolution and there can be microvascular recovery, then you can go for the stent implantation. But however, there is a caveat for this. If there is patient is having a chance of risk of reocclusion, that is very common, up to 5 you can see. So you have to actively choose the patient, and also you have to take into consideration the patient clinical symptoms and also the disease changes and his hemodynamic stability. So STEMI trial showed a positive benefit, but however, a conflicting evidence is seen. So that showed a neutral benefit. There is no hard and clinical benefit also. This is the algorithm showing the management of thrombus. Patient small thrombus, you can go. The patient have a thrombus, but go with the manual thrombus aspiration. Large thrombus, you have to do the modalities, strategies that has got a synergistic effect. So because the thrombus that is, another thing is cataracts that is available right now. Patient is not having incredible flow, that is distal TMI 3 flow, then you have to go for the deferred stenting so that you can avoid the stent thrombosis. Thank you.
Presentation, the height burden, where we come into a conceptual framework of clinical decision making by aggression, containment, and avoidance. So we'll go back to the what we show you was done from so the patient of the so he wired we engage which, three wired vessels. So here we catheter to lyse the thrombus to avoid embolization, and doing multi-laser passes in AD first. Then we all passes in the diagonal. After doing the laser, the flow is slightly better. So we went ahead. So diagonal, after doing this thing, we imaging to see exactly what's going on there. So we can see the red thrombus sitting there and causing luminal comps. And as we come to the proximal part, we can some amount of calcium is there. Now the huge LED ectatic around 4.5 mm diameter. And then as we proceed ahead till there is arc, but the established. So when we see the section wise in the distal landing and then proximal part, we can huge chunk lesion in uh, the plaque modification here. After doing laser, we thought we should cut the lesion to lumen gain. So we also took a run in diagonal, so we focus more. There is some fiber plaque, and we can see the nice dissection. The inside that must have caused, but the main important aspect in this is the osteal tight. So if we the by going by imaging, so now it's a true bifurcation lesion. And there is a dissection in so now the thing is to open up the ostium of diagonal, open up the LAD, and then decide what is the strategy. Dilated the diagonal, dilated the LAD, and that is the here. So here now we've of the diagonal dilated, and also now I'll the form open for the decision that how you now still go for provisional or we go directly for the D.
I think vision in the diagram is very disc. probably the best one. And only thing you will be which is still present, whether it will embolize distally. That is the only concern. But I think provisional stenting is the best.
So there is the ostial lesion of the diagonal is discrete and it is less than 10 mm. So then we can go for the provisional approach only. And before going with rotation of the ostium of the diagonal, it's better to do with a cutting balloon so that we can avoid an acid dissection of the diagonal and preserve flow in the diagonal. Time is a there is a nasty intersection in the, and we have to commit for the double vessel dedicated bifurcation stenting. So preparing the ostial lesions which are mostly fibrotic or calcific with a cutting balloon will hand the ostium so that we can go with the provisional approach comfortably.
I know, sir, but I would agree with the same original approach in the diagonal. And the flow in the LED also has improved after our preparation. So let's just see the.
When you see the bifurcation, you classify based upon the definition criteria. Is it simple bifurcation or complex bifurcation? When the length is less than 10 mm. Even if you see the EBC guidelines, the side branch length is less than 5 mm. This comes under classic simple bifurcation. So DK crush, though the fifth study, where it showed superior results even with the provisional, they compared DK crush with provisional. Even in simple bifurcation, only study which showed superior results even in provisional. But like if you take EBC studies, EBC main study and other studies, simple bifurcations, provisional is the best strategy. The restoration rate is more when you go with the DK crush. So complex bifurcation, they do extremely well with the DK crush compared to provisional stent. So this is a short segment limited to ostium, less than 5 mm and more fibrotic. So because more fibrotic, as Partha mentioned very clearly, you have to prepare lesion well with a cutting balloon, open it, and if needed, because it's a reasonably very long length, it's a very long length. So ideally, put the provisional and go with DCB or simple NC. See that this is nice flow, antigrade flow is maintained. The residual stiffness is less than 30%. Criteria you should say there is no flow limiting dissection. So after provisional stenting, flow limiting dissection is there, residual stiffness is more than 30%, and flow is less. Then you are forced to go with T-tap. So initially go with cutting balloon, prepare well. If need a DCB, provisional stenting, then go with if side branch pinches, go with these rescue techniques. Either go with T-tap or go with convert into. Here possibility of collect less likely because the side branch is very small compared to that. Only thing is you have to go with the reverse crush. But reverse crush, the problem is the resistance is very high. That's the reason avoid that one. Only best technique is T-tap. Or else you can take the Boss technique. Keep the balloon in the main vessel stent and pull the stent and inflate and see that it's not fully projected into the main vessel stent. So these are the options. You can proceed.
So let's see how the diagonal looks after we've done the scoring balloon dilation. So this is the OCT run of the diagonal after the scoring balloon dilation. So diagonal is around 3 mm here, and we can see that no residual stenosis, some dissection we can note. And then we're coming into LAD, which is heavily laden with the thrombus there. And as we can see that the thrombus, and we can follow that, the proximal landing in the LAD. So now here we have decided that we go ahead with provisional stenting, recross and dilate the side branch ostium, and we'll do a DCB there, because as we have seen that documented, no residual stenosis, no flow limiting dissection. So we are going here with stenting. So we took 3.5 into 28 Zions and then deployed the stent. you see that the thrombus is plastered at one side. Flow is maintained in the vessel, TIMI3 flow. The side branch, we can see there is some pinching there, but no flow limitation. So after doing this, we took a pot 4.5 into 8 the sizing is based on the imaging. So pot was done. After doing pot, we can see there is some thrombus protruding inside the stent. That was expected because we were plastered and that thrombus may prolapse back. But still, the pot was not enough. So we upsized it to 5 into 6. After dilating, we can see the thrombus protrusion into the LAD. So now what we did here is we did a kissing balloon dilation, putting 2.510 into diagonal and 4 into 15 into the LAD. And after doing a kissing balloon, we can see in the last injection, the ostium of the diagonal looks okay. The prolapsed thrombus is gone. The flow in the LAD is maintained. So finally, taking a drug-coated balloon and deploying a 2.75 into 20 drug-coated balloon. And first we deployed the drug-coated balloon for a minute. And then last 10 seconds, we've done a kissing balloon inflation to prevent the geometry disturbance. And that is how the thing was done. So now here we lost our OCT catheter. So we had to go for an IVUS. So again, the IVUS record in the middle picture, we need to focus there because it will show us the myocardial bridging, which we were discussing first in the first part of the angiogram part. So here we can see nicely the distal landing is good. Distal edge, there is no dissection. We can see a thrombus layer tacked on one side of the stent, and we've got wonderful luminal areas. And the areas are more than 12 mm square, which is a wonderful areas to achieve. And we've gone for the diagonal also, some dissection, but no lumen compromise. And ostium part of the diagonal, again, we've got around 7.8 mm square. So that is a very good areas to achieve. And this is what is the final result looks like. A TIMI3 flow with the bridging, which is very clearly appreciated, and well preserved diagonal. So that is this result was possible by using the laser catheter, which modified the plaque very well, avoided the distal embolization of the highly loaded thrombus, and doing with only single stent, reduce the complexity of the procedure. So that is what is the evidence-based medicine, which was applied and got a wonderful result. So I'll keep forum open for the discussion, and let's see what we can get additional from this thing.
The only thing is the point of discussion that one can think of is whether one would have considered putting a stent across the diagonal stent, and below where the stent, where there is thrombus, a covered stent. Do you think that possibility is there?
Because covered stent resource is more. And ideally, there is no drug. So now it's completely under the image guidance. We have seen the completely thrombus is pushed and almost 50% of thrombus burden removed. And it's very well opposed, expanded. So when the death is providing a good expansion, ultimately the long-term prognosis depends upon the only max criteria. Very well opposed, expanded well, and no medial dissection. So these are the important features. And here I wanted to say a few points about the hybrid strategy. Hybrid strategy means either put the DES, then diffuse disease there distally, put the DCB or side branch. There are two trials which are very important. Everybody should know. That is the first agent trial, ideal agent trial from Boston, where they compared agent DCB plus NC balloon. They compared with this side branch. But the results are far superior compared to NC dilatation. And another one study from the China, that is the DCB bifur study. Another DCB side study is there. These studies showed when they compared with the NC versus DCB for side branch, especially bifurcation lesions, the restenosis significantly fell down, up, especially the side branch. So that's the reason now it is well recommended, because if you put a one more stent, you are adding additional metal layer. More stent layer, more restenosis. So compared to single stent, two stents, more restenosis. So advantage compared to NC balloon, DCB balloon, because restenosis is less and because the myopical proliferation less. Here we prepared very well with the cutting balloon, because the cutting balloon, what happens, it creates a fine incisions, fine cuts. So when you apply the DCB, what they attributed, because drug permeates through that fine incisions, it percolates into the tissue, so that the restenosis will be less. The first study we showed the significant benefit is our 4 study, where they compared angioscalp plus DCB, almost 40% reduction in the MACE rate compared to NC preparation. So that's the reason always lesion preparation is very well. So this is a nice case to show LCA plaque modification, reducing the plaque burden. And you see at the end, clearly the TIMI grade 3 flow, thrombus, you are unable to see. Imaging showed the IVS was used mainly because at the end OCT catheter was not working. So because of that, initially some artifacts because of the large thrombus burden, but otherwise very nice views. I think I request everyone to say a few words about then we can conclude the case.
So
We
just
start
for,
with- yeah.
sorry, just for discussion purposes, anyway, we don't use thrombectomy devices on routine cases, but when there is a large thrombus burden, when we choose between laser or mechanical thrombectomy, do we have any guidance?
Some cases, some patients are too resistant. Multimodality option is always works. You can aspirate, you can give a thrombotherapy, you can use the laser. It all depends upon thrombus. So try with one technique. If you are not satisfied with the thrombus burden, then use the intracoronary. If that is not there, use the LCA. Other way around, you can start with the LCA, and if it is not, you can go with it. So multiple. So sometimes we can distally also you can put the balloon. Some people advised put 2 wires, macerate the thrombus clot, 2 or 3 wires, and rotate it so that it disintegrate the plot. After that, the aspiration, like a reolysis, the thrombectomy will become more effective. That way also you can try. Then Rajaram, you can.
Sir, I have one doubt. So,
Yeah,
Thrombus aspiration. These are not the ideal. Case is not changed with us. With a more organized thrombus.
sir, I have one doubt. So, can we identify the ruptured area, plaque rupture area, when there is a large thrombus burden in the coronaries, like in this case?
Large thrombus burden is there. What happens? Initially, if you aspirate the thrombus, most of the time it will be you can identify very clearly. But you have to see frame by frame. So usually plaque rupture with thrombus, I feel it's mainly proximally tight fibrotic lesion, and because it's ectatic, that led to thrombus because the flow is sluggish. But we didn't see any plaque rupture. Plaque rupture usually will have a large lipid core, classic picture, large lipid core, and at the same time you can see the ruptured plaque and empty cavity, everything will be visible. We don't see that kind of picture here.
Sir, one more doubt is that in this subset of patient where we have seen so much of thrombus, is it wise to put the patient on 1 month of triple therapy with anticoagulation and DABT, or better not to go ahead with that?
So once you have an optimal criteria, no need. So stent is expanded well, opposed very well, and no medial dissection. Standard stick to only DAP therapy. And there is no indication for that one. Right now they recommended additional anticoagulations only if they have a atrial fibrillation.
Okay.
No other circumstances they have recommended. Yeah, Vijay Kumar, you come forward, Adichie. You can. And now, just now, Dr. Vijay Kumar Reddy joined, senior consultant. You can sit here. You can discuss. Come here. Come here.
Hello. It's a very nice case. It is TIMI for thrombotic grade. So it is mo- it is TIMI for thrombotic grade, which is more than 2 diameters of the vessel. So there are two options. One is immediate stenting. When the TIMI flow is 0, 1 or 2, you can do immediate stenting. When the TIMI flow is 3, it is always in case of large thrombotic burden, better to do what is called deferred stenting by giving that GB2B inhibitors and other drugs. So here we did the deferred stenting after giving the GB2B inhibitors. And one more thing is when you find large thrombotic this thing, when there is a here we can give 1/5 of this thrombolytic. Also, that is also one of the option to dissolve the thrombus. That is one aspect. And the vessels are somewhat ectatic. And finally, OCT and doing with, I think we'll put 5 size, 4 size stent and optimized with 5 size with the final good result. Thank you.
What is the time now? Over 1 hour?
47 minutes.
Yeah. We have 1 hour time. All of you can raise some more. See, actually in acute setting, whether you want to go with immediate stenting or deferred stenting, it all depends upon the clinical condition of the patient. Okay, sometimes patient is a florid pulmonary edema. See, we have treated one patient similarly. Very large L6, thrombotic lesion, thrombus containing, patient has a florid pulmonary edema because of the acute MR. So we gave a intracoronary thrombotherapy, we gave a glycoprotein 2B3 and a ventilatory support, we gave IABP. We waited for 3-4 days and the heparin was continued. And 3-4 days later also we repeated angio, but flow established, but thrombus burden was more. MR was there, but gradually over a period of 10 days, his symptoms subsided. Dyspnea came down, we weaned off the ventilator, and patient became stable. And we called him 1 month later. 1 month later, then we stented L6, and that time even he had a LED radiolucent area, very, very tight. We did the OCT. While doing OCT, while crossing with the wire, it got closed. Then why it's called, it's looking a very short segment, tight stenosis. I thought, let us see. When we did the OCT, there was a reconlay thrombus. So reconlay thrombus, sometimes, see, previously he might have had a LED lesion, reconlay is stable, but this time patient developed a L-sec lesion, and which was very thrombus. That is like when storm is there, never go for boating. You wait until it subsides. So that's the reason, even if patient is having a severe, wait, put the IABP, put the ventilator, everything. If that is not there now, at least we have a thankful to the ELCA. ELCA is a wonderful, even acute lesions, we can try 4-5 times increase, and most of the time. I think Pranay, you can discuss about the ELCA technique, like a forward movement, backward movement, like a saline, everything, because we did ELCA. You take.
So laser catheter is a very handy tool to use. It is basically just like a balloon crossing through the lesion and coming backwards. The only important thing here doing ELCA is we have to be gentle and we have to be slow. And because there will be heat generation inside when we are lasing the lesion. So we need to flush it with saline. So the continuous saline flush is very important during the ELCA. And we have to also make sure that there is no contrast inside the coronary when we are lasing the lesion. So the laser works in two things. By one is the rate at which we are lasing, and one is the fluence, which is the force which we are applying to lase the lesion. So we begin with a lower rate and lower fluency, and then we slowly escalate it to the higher fluence and higher rate, depending on how easily we are crossing the lesion, how in the way what we are achieving the flow. So when we are using laser, so it is best works in fibrotic lesion where we are not able to get the balloon down. Getting gadgets down, it is very difficult. So it pulverizes the lesion, makes it softer, and then it is very easy to get the gadgets down there. The other indication is some at least mild to moderate calcification. It works fine, but in severe calcified lesion, it doesn't work. Thrombotic lesion, again, it has got a role where it lyses the lesion, it evaporates the clot, and that is how the laser works there. So it's a very fine catheter, 0.9 mm. It's an over-the-wire catheter where we just calibrate the catheter first, introduce it into the system, and then we can just pass it like a balloon, which we usually done. Very easy to learn technique. But there are some technical aspects which are to be taken care of. Otherwise, we might have problems of like injuring the artery or getting a coronary perforation.
There is one hypothetical, another question, sir, just for the sake of discussion sake. In acute MI situations, when vessel is closed, still do we need to wait for thrombus to dissolve for 2 to 3 days or 1 day or 3 days? One is one hypothetical situation where in acute MI situation, there is in spite of your wiring and balloon dilatation, we often encounter that there is a complete obstruction to the flow, 100% occlusion to the flow. That is one condition. And second thing is, suppose if you are giving GP2B3 or other means, how many days would you like to wait? So these are the two questions.
For surgery, general, glycoprotein. Yeah.
How many days after how many days you want?
No, actually, it all depends upon the clinical. So acute MI, when the total occlusion there, we are not sure. It's a total, what is the length, the burden, everything, you are not sure. Only thing is put the wire, cross the wire and dilate it. Many times in acute MI, within 6 hours, just now Dr. Shailen Singh sir mentioned, acute MI, short period, short window period, what happens at radio recent and usually easily it will come. But once it organizes, it is resistant for aspiration. More than 6 hours, usually it will be resistant. If a patient, he may be having MI, but 12 hours later it comes, most of the time it fails. And at the same time, if long-standing occlusion, what happens? Always the distal thrombi will clog all the capillary bed. So that time when you dilate, it may go and it may lead to, and you have to balance the risk versus benefit. Is it myocardium, is it viable? Ongoing pain is there or not? Suppose myocardium is gone, then you are very sure that tissue edema is there. That time we are creating more problem to the patient. That time you have to be very slow and aggressive. So always balance the risk. Whether patient ongoing pain is there, that means some viable myocardium is there. ST elevation is there, myocardial thickness, all these parameters should be considered. Glycoprotein 2B3 always it blocks all the platelet activities, all the receptors of glycoprotein. So as long as the platelet survive, this effect will be there. So the glycoprotein 2B3 blocker effect will be there until 5 to 7 days. That is the reason. But during that time, okay, next day you are given. Patient improved hemodynamically, pain-free, LV is improving. That means recognized. You can recheck. If needed, give a small injection, recheck how is the thrombus burden is less, flow is established or not. If flow is not established, then go with ELCA, other modalities. Then ensure that provided that is going to benefit the patient, myocardium is viable and fully functioning, or it is partially viable. In that case, it is going to be helpful. The ELCA, regarding ELCA, the advancement should be very, very slow, only 1 to 2 mm per second. And don't keep laser at one point. If you keep one point, it can cause the tissue vessel damage, perforation and everything. And always it should be though people are using blood-based laser, they are using the contrast-based calcium, but you have to be very, very careful. And those things is advisable only for calcific lesion, not for fibrous lesions or thrombus lesions. That time when you give the calcium, many times what happens is because of so much heat generation, The perforation complications, sometimes you may get away, but in the beginning, don't try. But really resistant cases, carefully you can try such type of things with a laser. I think we can, sir, finally you can, both of you can say final conclusion and then we'll close the session. Dr. Shailendra.
Very nice case. Demonstrated how an organized clot in the coronary artery should be treated. And it's very, very important also to know that the clot is fresh or the clot is of some age. So if the clot is of some age, then this approach is probably ideal. May or may not be ideal for a fresh clot. For a fresh clot, probably CAT RX will do the job. You don't have to do the laser. But I think it's a very nice case, very nicely presented. Thank you.
So thank you very much for attending the Zoom meeting on the behalf of the Sunshine Heart Institute. It is a highly informative and educative case, large thrombotic burden in a ectatic vessel, how to treat and what are the various modalities and what are the technical difficulties and technical tips and tricks we can learn by this Zoom meeting. I think we'll have that same type of meetings in future also. Thank you.
Thank you.